right, we're ready to start. Hello, everybody. I'm Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have a superb meeting because we have a great topic, a great panel, and a lot of great participants. Today's topic is the modern revision hip, not the Charnley hip, the modern revision hip. Okay, and we have tonight with us three great panelists. I'll introduce them and I'll have them introduce themselves. Kris Alden, why don't you introduce yourself? Tell us where you are, what you're doing, and whatever you want to say to the group.
Sure. Well, thank you. Always great to reconnect, Ira. It's been a while. Good to
Yeah.
see you. I'm working in the slums of Aspen, Colorado, and still doing a lot of revisions. I'm about 30% revision arthroplasty, both hip and knee. And I would say that the revision burden isn't going anywhere, and in fact, it's probably growing. So it's always nice to talk about revision hip arthroplasty.
Excellent. And we have Colin McNamara. Colin?
I'm from the University of Miami. I'm 3 years into practice. I'm over 80% revisions. I do probably 40 plus revisions a month, bulk of my practice. Really keen on infections. That's my true passion, but I'll take on pretty much anything.
So all the people in New York who winter in Florida get their primary in New York and they go get their revision in Miami, it sounds like.
I have a pretty large catchment area.
Yeah, I'm just making fun of my own city. So we have Anton Kurdin.
Yeah, hi everybody. Thanks for having me. So I'm originally from Toronto, Canada, but I work at just north of Sacramento in California. My practice is probably 20-30% revision. Never thought I would be doing this long. I thought I'd just be a primary guy, but I started early in practice and just kept growing and growing. So I'm quite excited to talk about it today.
All right. So let's start off, Kris. Tell me, you started talking about this. Tell me about the revision burden. Not only the numbers, but what it really means to you.
Well, I would say, well, total joints obviously are growing as we have the silver tsunami, the aging population, and also on the other end of the spectrum, people are less tolerant of an impaired lifestyle, and they want to get back doing activities, whatever that is, hiking, biking. Um, we see people, out here all the time, the weekend warriors that are out in the mountains. And, it's just so we're seeing obviously younger people getting primaries, older people getting primaries that want to stay active. It's just a different world now than it was, you know, when I started in practice in 2008. There was this sort of dogma. You have to wait till you're 65 to get a joint replacement, but obviously that's dramatically changed. But on the flip side of that, people are, periprosthetic fractures, infections, revisions, dislocations, all those, pathologies are growing along with the primary volume. So, and I think in general, there's probably, revisions are probably being more concentrated into necessarily academic centers or centers of excellence or specialty areas, specialty physicians that are more interested in taking care of those problems than probably what was more ubiquitous, 10, 15 years ago.
Excellent. Colin, what do you think about it? You're seeing, you're in a big city in Miami, and you guys probably talk about this a lot at grand rounds.
So I think first and foremost, biggest thing is preventing infections, which is what most of my research is in. 40 years ago, we started using ANSEF as prophylaxis. We saw a big reduction in infections, but really that's plateaued. Most of that's because every intervention we have that reduces infections, we get that much better at catching infections, and it's like we reduce them, we catch them, reduce them, and catch them, and infection levels have stayed pretty much constant for 40 years. a lot of my research has been in iovancomycin and in iodine for preventing infections, but the bulk of my practice is treating infections. And a lot of what you'll see from my cases is using revision stems, but more or less as spacers, both for 2 stages and also for like 1.5 stages, trying to get some permanent fixation, but with antibiotics to give patients stable fixation, treating fractures and infections at the same time, etc., getting patients mobile, but treating infections and getting patients cured, getting them back to normal life.
Yep. And Anton, you're kind of earlier in practice, but 7 years is not so early. You're at that 7 year itch. What are you seeing up where you are in Sacramento? Tell us
I
about
think
yourself.
what Dr. Alden says is 100% true. I think everybody now wants a hip or a knee replacement. Everybody always wants to be quick to jump into surgical options because the expectations on the lifestyle are huge. And I think locally, what we've seen is joint replacement has become so common that a lot of local orthopedic surgeons, even though they may not be trained in arthroplasty, they're essentially changing their practices to doing arthroplasty cases. And not necessarily that's what's driving the revision, but I think just the sheer volume of cases, that's what's going to cause some complications now. They are, I think, are improving, but I think, yeah, instability, dislocations, infections, fractures, that's what we're going to have to deal with the next 20 years.
So I think of three categories of causes of revisions. Patient factors, surgeon factors, implant factors. Okay, let's talk about some patient factors that are causing revisions. Colin, you seem to have a good handle on what are the patient factors and what do we need to optimize to prevent these revisions?
Yeah, so hemoglobin A1C, BMI, smoking are all modifiable risk factors. You really don't want to deny patients um, primaries, but you really want to optimize them first. So, for instance, the patient whose BMI is 42, if you tell that patient you can never get a knee replacement, they may go on to die of a heart attack, die of a stroke. But if you can get their BMI down to 37 before you do it, that'll make it a heck of a lot safer. So
Right.
really getting that patient optimized, working with nutrition, getting them on the GLP-1 if you can, working with their primary care doctor, working as a team, working like with the entire healthcare system. I work at a university, so it's very easy for me. I make a phone call. I don't even necessarily have to do it. My MP does it, and all of a sudden, 5 other doctors are involved. I have a group chat in Epic, and I'm keyed in with that patient. I see them every 2 months, every 3 months, and maybe I do their primary, 18 months later, but in the community, it's a completely different thing. Sometimes people are doing primaries on patients who smoke, their A1C is 8, 9, their BMI is 40 something. And then as soon as that patient has a complication, they dump them off at our front door, and it's maybe not really what's best for the patient per se.
Yeah. Kris, what are your thoughts about patient factors?
I would say if their A1C is higher than their hemoglobin, that's probably a cause for concern. Um, you know, host, like all the things Colin said, anemia, I think that's kind of an underappreciated issue. Because that can be sort of a sign of lingering health problems that aren't really known to the patient or the primary care doctor. And then just the bone quality. And as their bone becomes poor, that can certainly drive different pathologic conditions that can result in revision arthroplasty. So, soft tissues, if they're particularly in the hip, I think that can be a cause for dislocation, things like that.
And Anton, I'm going to ask you a slightly different twist. What are some surgeon factors that are causing revisions? I'm going to put you on the spot
Thanks
because
for that.
you're the youngest one, and we can wipe you out just one
So
phone call.
I always try to kind of reflect on my career. I finished fellowship. It was 5 volume. I thought I was good early in practice, but even looking back to what I did 7 years ago, that even now, I think it was a mistake. I didn't have experience. I think inexperience is definitely a big one, right? I think a lot of cases, as I mentioned, especially the primary ones, are done by certain surgeons that they don't know how to deal with complications. Intra-op, if they cut the MCL or the MCL peels off, they don't know how to manage it. They'll try to repair it. They might even, keep the same medial constraint poly. And so I mean, it's a tough question to answer, to be honest
Yeah.
with you. But I think every surgeon they try to do what's best, but I think the skill or education or experience may not be there. And obviously, there's a huge, financial incentive, right? If somebody is, trying to fill their clinic, trying to fill their OR schedule, I think there are some factors that are not right. But at the end of the day, for community surgeons that I see in where we practice, they're trying to fill their lists and they're trying to do cases that perhaps they should not be doing. But again, it's I don't think there's a one single factor. I think it's multifactorial and it essentially depends on experience, education, and what they're comfortable with.
We have a question from a surgeon younger than you, Dr. Plancher.
Oh,
Um,
I like that. That is honored. Ira, directing I thank Anton for being honest, but I'm going to push him a little more and the panel. Why don't you think it's all financial? And Colin, don't you have a responsibility to speak out to your private practitioners and cut this baloney because volume is the search to the bottom of the sea? And maybe, as Kris will say, you do deny people, and I'm proud of you, their primary until they can get their hemoglobin A1C down or the GLP-1s. And isn't it time that we became the leaders and not the sheep and do it and call people out as a business community does calling people out all the time? We're taught to be nice, but we're hurting patients. And so I ask you to reflect on that because are you only worth $900? Do you even know that's what you get? Because if you do, you know, family members can get their hair colored for 800. So it's more a reflection, and I would love to hear, isn't the primary cause, Dr. Kirschenbaum, financial?
well, what do we think? Kris?
Yeah, I would say as Medicare has cut arthroplasty substantially over the past, 20, 30 years, really we always kind of adapted and we just thought, okay, well, we'll do more to make up for that lost revenue. But I mean, I think it's really, well, it's been a crisis and it's now going to become even more of a crisis, as Kevin was saying. I mean, so I have criteria. I won't operate on people with elevated BMIs and poorly controlled A1Cs. I just tell them, I'm sorry, but you're not safe to get a knee or hip replacement and go see your primary care doctor. But it's going to become even more problematic, and access to skilled orthopedic surgeons are going to be difficult if the continued um, you know uh, rate cuts get implemented. So I'm not sure. There's always going to be somebody willing to do it, and I tell patients that I'm like, if you go looking, you'll find somebody, but I don't think you're at a point where it's safe to do your hip or knee replacement, and you need to be optimized better by your primary care doctor
Yeah.
just to keep you safe.
So let's pivot to the prosthesis now. And there are two parts to the pivot to the prosthesis. One is, the surgeons who may not use the correct prosthesis in the first place or put it incorrectly. That's one thing. But more importantly, what you use for revisions and what system you like to use. Um, as a comprehensive system from primary all the way up to revision, which I find that a lot of casual arthroplasty surgeons don't have backups in their on their shelves. And let's talk about that concept of the comprehensive linear joint replacement system and versus the people who just go in with the primary, and if something, if the femur fractures, they got to call somebody to then travel over the bridge to bring stuff in. So, Colin, why don't you talk about that concept of if you're going to do a primary, you got to be able to do a revision, or
Hmm.
that kind of concept.
So I'm very fortunate that I'm at a university. Everything lives here, from all different types of primary stems, all the way up to proximal femurs, total femurs, etc. lives on our shelf. About 90% of my primary cases, I use a collar triple tapered stem. Probably about 10%, I use a polished slip cemented stem, depending on the patient's bone quality and age.
Mhm.
Um, and then on the revision side, it really depends on like very patient specific factors. I think we all use the Resolve, which is like the sponsoring institution for this journal club, but otherwise, really it depends on patient factors, and each case is individualized for revision, so it's kind of hard to generalize what I use in
Okay,
general.
sure. Anton, what you're in a
So,
you may be in
yeah,
a different setting. So what's
I'm
your
at a community hospital. When I first started, I learned a very good lesson. And it was actually on a knee. I get a call from my partner. It was middle of clinic, and he says, "Get in here." So I get to the OR, and he was doing a total knee, and I don't know what happened, but the MCL was cut, the posterior capsule was cut, and the knee was hyperextending. And we tried to distalize the femur, we tried to play around with constraint, but it wasn't working. So I said, "All right, let's do the hinge." And I look at the rep and I say, "Bring the hinge in," and the rep looks at me and says, "It's not here." And you're used to all of that because that's what academic hospitals have, but community hospital, it's not there. So I put a spacer. We closed it up. The plan was to come back the next day. Guess what? Patient gets a PE, and then patient cannot have surgery. Patient has to be um, on blood thinners for a couple of weeks. So from then, I learned a lesson that all these things have to be on backup. And it was a struggle, I will admit. It was a struggle. I went to one company and said, "Hey, do you mind putting a revision femur in case I break something, if something happens?" They said, "No." I said, "We'll bring it in if you need to." But no, we don't want to put it. It's costly for us. It's bringing implants, bringing trays. We don't think it's a financial benefit. So that's when I had to talk to somebody else. Can you bring it on a shelf? Can you put it on a shelf? And honestly, that was a big struggle to have everything available. And the scary thought is that there's probably a lot of places in the country that don't have these things on the shelf, right? So yeah, for me, I luckily I learned early on, and now I bring everything possible because at a community hospital, there's not much.
Yeah, Kris, how about you? Where you are? You're in a sophisticated community. We met on the street one day in Aspen. We were walking by, and
Right.
very very
Fourth-
friendly
Yeah,
town.
4th of July.
Fourth of July. Yeah, yeah,
Well, it's interesting. It is, obviously a ski resort, but it is a community access hospital, so it doesn't have all the bells and whistles. We don't have in-house cardiology or interventional cardiology. There's a lot of services we don't have, so it is very much, we're kind of managing a lot of issues, both medically and orthopedically. So I will have, but that said, we can still do complex surgeries here.
yeah,
So I will have plan A, B, and C, and just in case, something happens, it's always nice to have those backup systems available so that you can just bail to a hinge or to some type of more complex revision system, on the hip side or the knee side.
yeah.
So I
Anton, you have
definitely have those because I've
Ira,
been in those situations.
yeah. Kevin,
Ira,
Kevin, yeah.
can the panel talk about what they like in a revision hip system, whether it's Resolve or others, what they select that they like that makes a difference, they believe, for their patients? what is a revision hip system that they would advise all the people listening to look for as experts that they know will help them as they if they ever were to get into trouble? Do you mind?
Yeah, let's start with Anton. Anton?
Um, yeah, I mean on the stem, I think so. I used a lot of monoblock revision stems, and monoblocks are fine for a majority of cases, but um, sometimes monoblocks are not enough. So I think having almost like a comprehensive system that can get you out of anything, that's the big benefit. I'm a big believer in modular. I think a lot of surgeons are, I guess there's a trend to go monoblock, but I think modular still is the king for universal revisions that will get you out of trouble. Obviously, having length and sizes and having different options, right? The system I used to use back in the day, like years ago, the only way to grow offset was to put a bigger proximal body, right? Having different options, high offset, stern offset, and also growing the offset based on the size of the body, I think is beneficial. I mean, I think that's why we all use Resolve is because there's so many options. And for me, it will likely get me out of trouble any case I can think of.
Colin, tell us about your experience with the Resolve, or what are the features, as Kevin clearly said. What a
Yeah.
real down to earth. What are the specific features? Because not every system has.
Yeah.
They're not interchangeable on the market.
Yeah, absolutely. So like one of the crazy things is like I use the Resolve a lot as a spacer because a lot of my cases are infections, but a lot of my infections also have a lot more going on where the patient has an infection and they have a fracture, or they have an infection and they're chronically dislocated and they're very short. And a lot of times you would think you want a monoblock stem as a spacer, but that's not always the right answer for every patient. And if you have a fracture you're dealing with, or you may need to successively lengthen the patient, etc., the Resolve has a lot of options that other stems don't have. And that gives me a lot to work with. So I'm filling the flutes with cement. Oftentimes, I'm even coating the proximal body with cement as well. But the Resolve gives me a lot of options that monoblock stems and even other modular, like taper fluted stems, don't give me. And that's very valuable for my patients that are very complex infection patients, that other stem systems and especially monoblock stems don't give me. So I still use a lot of monoblock stems. I still use them a lot as spacers, but I'm using a lot of Resolve as well.
Yeah, Kris, your feelings?
Yeah. So I think that's a interesting question, Kevin. Thank you. So basically, I would say the most simple revision stem is the best stem. So you're treating the pathology and treating the patient's problem. So there are times where on some revisions, I'll go back in with a primary stem. I've done that many times because it's simple, easy, it's quick, it's efficient, and it solves the patient's issue. Um, and then obviously if there's bone loss or there's proximal bone loss that is substantial to the extent that you need to get metaphyseal engagement, then obviously there's a number of stems out there, but Resolve, in my opinion, is fantastic. And I've solved very, very complex femoral revision problems with this stem and solved it very well. And the other part that I like about it is obviously you have 4 centimeters of proximal body options, standard and high offset, so you can basically reconstruct the leg length to the extent and match up the other side, and you can give the patient a really functional hip that is going to be stable, secure, and provide good pain relief and restore their function.
We have a question from the audience, Dave Freshero. Dave, you want to unmute yourself and ask your question? If not, I'll ask it.
Absolutely. Thank you. Great discussion. Great questions from Dr. Plancher already. And so really enjoying this discussion already. Just while we're talking about STEM designs, I was just curious what design features of the STEM you find, in your view, can be beneficial to fix say, Vancouver B2 and B3 fractures? Thank you.
Awesome. Awesome. Colin, you want to take this one?
Sure. I mean, you can bypass the fracture. I'm not sure that that's unique to the Resolve over other modular taper fluted stems. The proximal body in the Resolve has extra size options, an extra centimeter beyond any other stem in the market. I think the Resolve goes, or like other stems only go up 3 centimeters. The Resolve goes up 4, so you can get more length that way once you sink the distal stem. But otherwise, I don't think there's any specific to the Resolve that is better than any other modular taper fluted stem for B2s or B3s. But modular taper fluted stems are great for B2s and B3s.
Yeah.
Yeah. I would just add that you get consistency. Like you ream, okay, I'm going to ream into get metaphyseal engagement. I'm going to ream to an 18. You put an 18 in, it seats exactly where the reamer went, where the trial went. And then you have so many options on the proximal body. So you can restore leg length and create stability. And then obviously adjust the version, offset, and create a stable construct. So I've been very, very happy with it.
Let's do a couple of cases. I don't know. Well, Kris, you want to go first? You want to present something?
Sure. Yeah, I can.
There must be somebody I sent to you
Yeah.
from New York who ended up in Aspen. Yeah.
There's a handful.
Yeah.
Can you see my screen now?
Oh, I see me. Yeah, now we see that. Yeah, good.
You see it?
Yep.
Wow, that's a miracle. So I always say, well, I do all my revisions anterior. People think that's kind of stupid, but I've enjoyed it. I've done 100% anterior for the last 15 years. Yeah. So this patient is she was 72. She had bilateral total hips in 2012, and then she had a periprosthetic fracture from a bike fall in Portugal, and she had it fixed there. Not to disparage the Portuguese surgeons, but it wasn't really, it was reasonably well done, but here's her fracture on the left and then the fixation on the right. And so they put this huge plate on. The stem was long. It subsided shortly after they put it in. So she had pain, she had a non-union, and she had this massive plate. So she was super unhappy. The stem was basically potted distally, subsided. She felt like her leg was like an inch short. So she just was super happy and she had constant pain. So I took everything out. I basically just took everything out. I actually took the cup out. The cup was loose. And I wanted to do a dual mobility to improve her stability. So I just basically hit the reset button on everything the people did in Portugal. I fixed the fracture, so you can see the Kinemed cables. I put those on very liberally, and then I plated almost the entirety of the femur up to, and not all the way up to the trochanter. Sometimes patients hate those trochanteric plates. I've actually probably taken out more of those trochanteric plates than I put in. But anyways, you can see I fixed the fracture, and then I love anterior revisions because I can read them under fluoro and know exactly where things are going. And then here she is with the fracture fixed, the metaphyseal engagement, and then the plates fixed her fracture, and she's walking extremely well. So she's super happy. This is actually the first one I did. So it's a 180 stem with a 95 proximal body. And she's been super happy. I got others, but I'll let other people show their case.
Sure,
too.
sure. Anton, you want to show us some stuff, and then we'll get some questions from the audience about it.
Yeah, I'll show my my first case as well, my first Resolve case. So I think everybody kind of hit on the point. Whenever we encounter these complex cases, I still worry about them. I mean, maybe I'm early in practice, maybe later on I won't, but I stress about it. And so here's a patient that's 57 years old, had a previous stage 1 3 years ago, then she disappeared. And despite what people think about California, we have pretty high BMI patients. So her BMI was well over 50.
Oof.
And this is something that, poor bone quality, obese, I knew this is not going to go great. And I used to use monoblocks for this, but again, with the monoblock, you have to make sure you ream, and then you always wonder, did I ream enough? Should I go with another one? Is it going to subside? Is it going to stay? So this is where, as soon as the resolve came available, I said, this is the perfect case. So luckily, she was not infected. And I try to go as short as possible because, in my opinion, once you're infected once, there's a possibility it's going to come back. So I didn't want to go really long, but I reamed. We didn't have to stress about the proper size. And even if the stem subsided, I knew I can work around with the body and still get her stability. And yeah, it turned out really well, and I was very happy with it. So this is, yeah, my first case, and I think patient luckily has not had an infection yet, and hopefully will not have an infection because she was quite large, and I really don't want to go back.
Tell me about the offset of that stem there, because that looks like a
Um,
very nice
well,
offset.
I forget what offset I use, but this is what I kind of mentioned the biggest benefit, right? Because before with the system that I use, I always went to 25 body no matter what, because that was the largest offset. Well, this system and the biggest thing I absolutely loved about it, there's a dedicated standard offset and there's a dedicated high offset for every body, but the body's offset also grows. So if there's so many options. If I want to increase the offset, I can go bigger on the body, or I could just use a dedicated high offset stem. And for patients like these, where impingement, whether it's soft tissue impingement or bone impingement, is big. I mean, she's huge risk for dislocations, right? So I believe I used a high offset, and I believe I used a 23 body on this. So I think that's enough offset for this patient.
It looks like a great result. Any comments from
Ira?
panel? Oh,
Can-
Kevin, you have a
Yeah.
question.
Can the panel talk about, because I'm too old, so in my day, it was the SROM. I'd love to know the improvements. It's clear, love the offset, um, that Anton or Colin or Kris talk about how the SROM was there, and this is kind of helping bring it to the next generation for the rest of the audience to talk about. I hear the generalities about, oh, I can do anything, whatever, but can you talk about the specifics if you had experience? And sorry if I'm showing my age with the SROM.
Well, I've put in some SROMs in my life, and I've also taken them out. It's a high quality stem. There's no doubt that proximal, um, that like proximal fill of the metaphysis, it fit the bone extremely well, and was a great stem for a long time. And obviously, changing the version, you can adjust for stability and create a very durable, stable hip. I think the benefit of this is we just have more options as far as offset and length.
Got it.
So that, well, I mean, I'm just speaking from an anterior perspective. I can fine tune under fluoro, and I know exactly where the patient is as far as length and offset, and then I can, adjust the version to create stability. And then the other nice thing is, I can show the patient, hey, this is where you were before, this is where you were during, this is where you are after. And the nice thing about the stem is you just have so many different proximal body options to adjust all that. So you can literally fine tune it, and create a very, very nice hip. With all due respect to the SROM, I mean, that was around for a long time and, served,
No, I
had a
know that's
fantastic.
first generation. That's why I want to hear
Yeah.
about the excitement of
Um,
this.
yeah. So this is just a little, and then the other thing is you can also just adjust the proximal body. Like I've been in the first one I did, I was like, I don't really like the version. I want to optimize it a little better. After I put the final proximal body on, and I changed it. I literally like took it out, adjusted it, put it back in, and it literally took me 2 minutes. So it's nice that way.
That's cool. Cool feature. That's good.
Yeah, I think
Arjun,
getting the
okay.
stem out of an SROM is not a fun, even though it's, you know, a smooth stem, it still can be a struggle to break that taper. You know, as anybody that's, you know, taking them out, it can be a struggle, and then they get cold welded. So
Yeah, it's
you know, my psychiatrist says I'm doing well with the PTSD from the SROM revisions I've done.
It's the only time orthopedics are experts in medication. Yes, I
Yeah.
get that. Arjun Patel, you have a question tonight. Arjun, you want to unmute yourself and ask your question?
Yes. Thank you guys for all this information. I'm just curious, when you guys ream for the stem, when you put in the actual implant, does it sit any higher or lower? Is it almost, from your guys' experience, usually at the level of the reamer? And is it the same for the curve stem, or like the 180 to 240 stems that you guys use, plus or minus the distal locking screws?
Yeah, so I would say it is somewhat predicated on the bone quality you're dealing with. So, for example, I had somebody that was, you know, I think she was probably 50, and her stem was loosened, and so I revised her, and so I would say in those cases where there's good bone and you get that robust diaphysis, then you probably want to, you know, sort of under ream. So ream to a 15, put in a 14 stem, and it's probably going to sit about where your reamer sat. But if you have the older patient with poor bone quality, then I would, you know, basically kind of ream line to line, and it's pretty consistent. It's always nice. I mean, that's why you shoot for the middle of the proximal body options, then you can go up and down 2 centimeters. So you got plenty of room.
Interesting. Colin, you want to present the case?
Sure. Let's see. How do I sent a share request? Let me go to here and then there. So you guys can see now.
Here we
So I
go.
didn't make an elegant presentation. I literally did 3 resolves last Friday, so I just grabbed the x-rays from all 3. But
That's
this
impressive.
lady, you might guess which side she came in needing a revision on. You would actually be wrong. It's the right side. She has significant poly wear on both sides. The cup has moved a lot on the left, but she actually came in draining on the right. She's infected on both sides. Needs a revision on the right. You would think probably like use a monoblock stem as the spacer, but I really blew up her femur taking that stem out. You would obviously plan for an ETO in this case, but as you can see, I did a little bit more than an ETO. I use those Kinemec cables as well. But here, in this case, use the resolve as a spacer, but also then I need to heal these fractures. In this patient, I'm doing a true 2-stage exchange. As you'll see as I go through my 3 cases from the same day, I use the resolve in 3 completely different ways as I go as I go through all 3 of them. But basically, in one day, use the resolve 3 completely different ways. But here, use it as a spacer, doing a true 2-stage exchange. Need to heal this bone that I completely blew up, and I need to cure this infection. But here, using the resolve as a spacer.
Wow. What so in this one, well, this just last Friday, so we're
Well, see how she does, but she's already feeling way better. I have her toe touch on that side, but
yeah.
she's actually quite happy. I fill the flutes, I coat the proximal body, obviously all poly cup with antibiotic cement behind it as well. But she came in draining significant pain in her hip. Already has a lot less pain despite how much I blew up her femur, but do have her toe touch, do need to heal that, and then I'll pull this out. And plan is to put a real cup, a real stem back in eventually.
Let's see your next case. Let's see what your day
All right.
looked like.
So this is a guy who came in. His primary surgeon thought he was infected because he had persistent pain after a total hip, but labs, inflammatory markers were all normal. Despite that, because he had previous fractures, previous hardware, I did an aspiration and a biopsy. That all came back normal. So I went into this case. Still kind of ambiguous, but once I was in, it was very obvious. The screws were blocking that primary surgeon's broaching, and I just decided to take them out because the stem was completely loose from that. And then I also did the guy a solid, as you can see on the lateral. He has this fracture deformity. I corrected that as well. Used the resolve to straighten out the osteotomy and made his femur straight again in order to one, fix the aseptic loosening, and two, to straighten back out his femur.
Wow.
How'd you do the osteotomy?
I actually went like slightly below the fracture site and created a triangle. I was originally planning on just going at the fracture site and cutting across it since it was oblique. But in the OR, it was easier for me just to take out a triangular portion of bone in order to straighten him back out.
Wow.
And then the final case, this is one I did with one of my tumor colleagues. One of my tumor colleagues had this patient. He had put a spacer in him. He had some sort of cancer, and essentially he had done a replacement on the guy for his cancer. The guy got infected. He put in this monoblock spacer. The guy developed pathologic fractures behind it. It loosened. The guy has a fungal infection. So he's dealing with two major problems, pathologic fractures and a fungal infection. Likely not going to cure the pathologic fractures, but we can give him better fixation and we can continue to treat his infection. So I pulled out the monoblock spacer, and we put a cage in as well. Again, I'm not trying to grab all of that bone. I'm really just trying to grab the cage with the cement in order to grab that for stable fixation so that the cup doesn't pull out, and then put in the resolve as a spacer here as well. Really, the goal for him, though, we implanted this resolve much more stably than I did on the first lady. This is more of a 1.5 stage. The goal for him is that this should hopefully be his final revision and to get him onto lifelong chronic suppressive antibiotics.
Wow, impressive stuff. Really, really big case. Kevin, hand up.
Sorry. So can the panel say, perhaps with all these higher BMIs and things, two questions. Is there a role for a DEXA scan pre-op for, not only women concerned, but men? And should you make that a part of your protocol? Do we have to think that maybe that's nothing, a lot of cables prophylactically? I like it because we know the problem. But is there perhaps a role and we change our thinking? I was curious what the panel thinks.
Yeah, I
I
would
throw
say
a-
I
oh,
would DEXA scans are helpful to some extent. I think I think that's really kind of an unsolved problem, to be honest. I don't think we have great answers for poor bone quality, and I've been in situations where I, was like, we got to bail to something much bigger, longer. You get the synthes plates out, you plate cable the entirety of the femur from the trochanter to the distal femur, to try to augment the bone and stabilize things. I think the role of allograft femur is really kind of coming. I mean, I haven't used one in a long time, so I don't think they're really all that helpful. But I think, Kevin, you're kind of hitting on really an unsolved problem, and hopefully there's ways we can hopefully ameliorate bone quality and optimize people better as we get into biologics and regenerative medicine.
Thank you.
Yeah, we have a question in the audience from Lisa Ogata, who having a microphone issue. Does anyone do girdle stones for infections, or have all these
Yeah.
incredible modular stems
I
negated.
had somebody with multi-drug resistant Acinetobacter, and there was nothing, and her bone quality was just atrocious. And I left her with a girdle stone, and she actually walked pretty well with that. So I would say that's not, out of the realm of possibilities, but it's a rare thing, I would say.
Interesting.
I've also reimplanted somebody that had a girdle stone. He was 7 centimeters short on the hip, and he was a retired orthopedic surgeon too. So, so never say never, I guess.
Or never retire. Okay, Arjun Patel, you have another question. Arjun, love to hear it.
Does the proximal body ever cold weld to the stem? Or like let's say, I'm just thinking about for the re-revision, if you ever have to go back in there, change the body, change the version for dislocation or whatever other reason, is it easier to just leave the stem in and change the proximal body, take the screw out, knock it off? Or are there times where you actually have to knock out everything?
I hope not. This has only been on the market like 6 months, but I actually have a young lady who, it's a really long story, but got a total hip when she was a child. And essentially, like, I am successively lengthening her once a year by planning to knock off the proximal body and grow her 4 centimeters. So I really hope not, but like, we have no way of knowing that.
Yeah.
I'd say in the times that I've revised modular type stems, I have not encountered cold welding. But I mean, I have seen it with, Kevin mentioned the SROM. I've encountered cold welding of the stem to the proximal body, and that can be a difficult situation to deal with.
All right. This is great. Let's I want Ashley, could you share your screen, Ashley, of what we talked about earlier? If you can. There we go. All right, just in case you thought it was safe to go back into the water, we're getting a bigger boat next week. We're shamelessly advertising next week's how to avoid disaster plasties to begin with. So I want you guys to register for that. We got Richard Bush, John Minter, and Herrick Siegel. So we're going from complex revision to disaster plasties.
Ira, the take-home message I have is how to avoid a disaster plasty. Just call Colin and send the patient to Miami.
Yeah, right.
I'm happy to take them.
Airfare to Miami is like cheap.
It's nothing.
It's nothing.
I think Allegiant flies down there.
Yeah. I mean, some patients are so difficult. I'll do a private charter. It's good. All right, so we could take that down. Just letting people know we're on this revision, circus. It's as always. It is. We have Raul Goss. Raul, you want to just comment on your cold welds that you've seen on some modular stems? If you're available.
Sure, yeah. Hey, thanks. Colin, how's it going, man?
I'm doing really well. How are you doing?
Good, man. Thanks. Good. We know each other back from Miami, but yeah, I wish I had the same experience. I mean, I just on Monday revised a long rest mod that was well fixed, and I knew it was cold welded because the op report from the previous surgery counter reviser 5 years ago said it was cold welded and couldn't do it. I tried to revise it, ended up breaking the extraction tool to try to remove the proximal body because I said, let me give it a shot. And that's probably one of like 7 modular stems, yeah, that I've revised where the proximal body was cold welded to the stem. That or the titanium set screw gets stripped by the person setting it, and then you have that problem to deal with also. So that even if you're not cold welded, someone might have stripped that screw for you, and that's a whole other thing.
Wow.
Yeah.
Just when it's safe to go back into the water, right?
Yeah, and then you end up doing either an episiotomy or a long ETO to get these stems out. The episiotomy did not work for me on Monday, so it was a long ETO, but it happens.
Where are
But
you?
yeah, so that's just to say that I'm now in Denver. I was in practice at Holy Cross in Fort Lauderdale for 7 years and Miami before that. Now I'm in Denver as of 2 years ago.
So you won't have to travel for AUKUS next year.
Correct. Yeah, exactly. Which will be good.
That'll be
But
good.
yeah, we see a lot of revisions here from all the neighboring states. We get a lot of them from Wyoming, Nebraska. So it's been fun.
Well, as I like to say, and Marty always hears me say this, this is the fastest hour in orthopedics, faster than all of you guys could do a revision, I am sure. But I would like each of the panelists to sum up their sort of overview of tonight and some advice for people who are going to take on these cases, I think, would be a nice take-home message. Let's start with Kris, then we'll go to Colin, then we'll go to Anton. Kris, some
Yeah, I
summary?
guess take home message. I'm super biased to the anterior approach, but I would say that there should the approach, the stem that you're using should be dictated by the pathology, not the approach. So you can do a long modular tapered fluted spline stem. The instrumentation is very anterior approach friendly, and so I've been very, very happy with it from an anterior approach perspective. And then the other take home message, I guess, be patient, go slow. So I will give myself 25, 30 minutes to try to get a stem out, and then I will go to the ETO. So I think repairing it and, you can still get great fixation, like in that complete, mess of a revision, the first case I showed. I tried to get it out. It was potted and well fixed distally and subsided. It was loose proximally, but I had to eventually go to the ETO. She had the fracture in there, so that kind of made the logical decision to do that pretty easily. But in general, I would say be patient and give yourself, just don't be afraid of doing an ETO from the front. It can be done. It's easy, and the repair is very simple because you're looking right at it and you got fluoro. So it's a great way to do a revision, in my opinion.
All right, Colin, you want to sum up your kind of view of tonight and prostheses and choices and
Thank you
where
guys so much. Thank you guys so much for having me. This was a lot of fun. I think if we're all honest with ourselves, probably the reason almost all of us chose to go into joints was because of revisions and how much fun they are. So don't shy away from doing revisions. Keep them a part of your practice. But at the same time, always reach out to your mentors, to your friends, prepare for your cases, and don't ever bite off more than you can chew. I think everybody from Dr. Parvizi or whoever you think is the best at doing revisions in the world probably still talks to their mentors, still talks to their friends, and still like reaches help for their cases. So always talk to people, always share your cases with your colleagues, and always seek advice from other surgeons and keep striving to get better, keep striving to do more revisions. And this is really what makes joints a lot of fun.
excellent. Anton, you want to bring us home?
Yeah, I mean, we talked about it. Having a plan A, B, and C is extremely important. Even in primaries, you don't know what's going to happen. I think you have to have something as a backup, and the one thing I like about Resolve is it will back you up with anything that could possibly happen. And revisions they are stressful. I mean, they're big cases, and I don't see a need to make it more stressful. And I think having a modular stem, like I said, I'm a big believer in modularity, will take the stress away. And since I've been doing modular stems, to be honest with you, my revisions, obviously they're always nerve-wracking. It's they're big cases. They're always last cases of the day. But I've been getting home a lot quicker and a lot less stressed. So I quite enjoyed my experience with it so far.
That's great. So, first of all, I want to say thank you to the panel. Thank you to all the participants who asked questions. This is always a great night with Joey night. Wednesday night is Joey night. So I want to thank everybody for coming. And it's been a really great night. And we'll see you next week on the new topic that we have. So thank you, everybody.